we have Dr. Cami Maddox from US as our guest speakers. This webinar is brought to you by Mumbai Hematology Group. It is supported by Lucian and managed by Perfect Square. I'm extremely thankful to Mr. Srivastava from the team Lucian, Mr. Yash, Mr. Kalpesh and the team Perfect Square, Executive Committee of Mumbai Hematology Group. Our guest speakers this evening, Dr. Ranjit Kumar Sahu from Delhi and Dr. Cami Maddox from US. All our discussants were themselves eminent hematologists or medical oncologists, and you participants for sparing your Thursday evening. Coming Thursday, we once again have two webinars, rather a webinar with two lectures. 6:30, we have myelodysplastic syndrome, the good, bad, and the ugly by Surgeon Commander V.A. Arun from Aswini, Kolaba, Mumbai. And then we have a pediatric topic, chronic ITP in pediatrics by Dr. Neeta Radhakrishnan from the PGI of Child Health, Noida. A word about our guest speaker today, Dr. Ranjit Kumar Sahu. It is my absolute privilege to introduce Dr. Ranjit Kumar Sahu, who is Professor of Medical Oncology at AIIMS, New Delhi. He is a highly enterprising, and I would still say that he is a young medical oncologist who stands out not only for his exceptional clinical knowledge, but also for the profound sincerity and deep humbleness. His dedication to patient care and academic excellence is truly inspiring. We are incredibly fortunate to have him share his experiences with us today. Please join me in welcoming Dr. Sahu as he takes the stage for his lecture. And the title of the lecture is Chronic Myeloid Leukemia in India, Our Experience and Future Directions. I'll stop here and request Ranjit to take over.
Okay. So, good evening, everyone. Is my slide visible?
Yes.
And is it moving?
Yes.
Okay. So, at the outset, thank you, sir, for those kind words. And it's my pleasure to present what we have done at our institute about CML. So, I do not have any conflicts to share here. So, CML is one thing, I mean, as we understood, it's a functionally curable malignancy. And these sort of survival curves are truly desirable for any cancer. So if God blesses someone, let's say with a cancer, let it just be, I would say, CML. And this is a publication which is still 9 years old. And if you could see, this is the landmark iris study. At 10 years, if you look at the arms, the arm above is imatinib, the arm lower down is interferon and cytarabine. You could see, even when you are not starting these cancers on effective treatment like imatinib, interferon RSC, I mean, that is an ineffective treatment. Then also you are not compromising with the survival a lot. Now, this study, overall survival was only a secondary endpoint. That's why in this picture, you would see there are no p-values. But at 10 years, the difference numerically is less than 5%. So the study wise close to 60 to 70% of patients who got the ineffective treatment subsequently received imatinib. So this is a cancer, even when you treat it after some time, the survival is possibly not compromised, I would say. So this is what happens in US. As you could see, this is a phase 3 randomized clinical trial who accrued patients between 18 to 70 years and the median age is 50. When you look into the epidemiology of CML, the maximum peak happens at 6th decade and it continues to rise till the mid 70s. And after that, the incident it drastically reduces, unlike many other cancers, where the cancers continue to, it is an aging disease. But in CML, the incidence, it drastically reduces after the age 70. You could see this is a phase 3 study. Most of the patients were in good performance status. So from the time of diagnosis to start of treatment, it is only 2 months in either arms. And when you look into the circle, close to 50% of these patients, they are so-called low risk. Close to 30% are intermediate risk. And 20% are high risk. So it is a very nice, let's say asymptomatic CML population. As you could see, splenomegaly is only found in a quarter of these patients. And massive splenomegaly of more than 10 centimeter below costal margin, it is not even, less than 10%. The white cell counts are in the range of 20,000. The platelet counts are well preserved. Hemoglobin is well preserved at 13. There are technically no peripheral blood blast if you take the median, and the basophils are just 3%. So we are looking into cases that we have studied a lot. It comes from the US, and you could see these are completely asymptomatic CMLs. And the charming thing is, even if you start these patients with effective treatment after a while, then also it is okay. So there is no hurry. So now let's come to the primary endpoints. As we have seen, even at 10 years with 1,000 odd patients, there is no overall survival benefit. So we are only relying on surrogate endpoints. So in the IRIS study, the primary endpoint was progression-free survival. It had multiple events like achievement of complete hematological response or a good cytogenetic response, progression to APBC. If they are happening, then it is counted as an event, or death. You could see there could be a difference in progression-free survival when you are starting these patients on interferon RSC, with imatinib over interferon and RSC, but there is actually no overall survival benefit. So this CML, at least in the US, it remains a malignancy where whatever you do, you are not getting any overall survival benefit, be it a first generation TKI, be it a second generation TKI, be it a further generation or a next generation TKI like asciminib. So whatever we found that we in CML, while we are conducting the studies, we are counting upon the surrogate endpoints. As of today, it is now, looking at BCR-ABL at multiple timelines, and that can tell you about the probability of PFS or the overall survival as seen in this picture. So in IRIS, it was PFS followed by decision. In decision, the primary endpoint was achievement of complete cytogenetic response by 1 year, which was close to 80% in dasatinib and 70% in imatinib. Complete cytogenetic response is also a very good surrogate endpoint that predicts survival. When you look into the next study, that was in a study, it was nilotinib versus imatinib. Won't go into the detail of the randomized arms, but you could see the primary endpoint in this study has further changed into major molecular response and not the cytogenetic response that was used in the decision study. Now, INEST has been a landmark study from which the primary endpoints are redefined as of today. As you could see, the MMR rates are higher for nilotinib of whatever dose, 300 or 400 PD versus imatinib at 400 milligram. once a day. So now let's come to the next generation TKI, like asciminib. You could see at 1 year, if you look at the BCR ABL of less than 1%, which predicts the overall survival, it is achieved with asciminib as compared to imatinib in close to 85%, and in imatinib it is 60%. When you look into the second generation TKIs, it is close to 90% in asciminib and 80% in second generation TKIs like dasatinib or nilotinib. Now the best part, if you look into the current set of surrogate endpoints, you would understand patients who are good molecular responders, they have better survival. And we can know it as early as by week 12 or 3 months. So by 1 year, if the BCR-ABL level are less than 1%, then these patients have an excellent CML specific survival. And the same thing, I mean, if you could predict it little early, let's say at 3 months, if you are having an IS percentage of less than 10%, then these patients, they tend to do good on a very long term. Should these patients be adherent to the treatment? So here, as you could see, if you are achieving a BCR-ABL IAS international scale of less than 10% at 3 months, these are the patients who achieve IAS at less than 1% at 1 year. Same here for the imatinib, for the nilotinib second generation TKIs, or for asciminib. If a person is achieving less than 10% with a TKI, he has the same chances to achieve less than 1% at 1 year, which is a good surrogate endpoint to predict survival. Now, why is it so? So, it is all about the way the BCR-ABL, the kinetics are happening, how the titers are declining. So, BCR-ABL in the first 1 year, it declines very sharply, as you could see in the first loop. And after 1 year, the decline is sort of gradual. You could see there are technically 2 slopes here. So because this is completely mathematical, and if at 1 year it is less than 1%, so at 3 months it is 10%. So it is a mathematical calculation. So you could predict patients who have got a very nice outcome even as early as 3 months. Now let's come to another study. I mean, we know we had wonderful outcomes with imatinib with respect to the survival, even though the molecular responses or cytogenetic responses were lesser as compared to the second generation TKI. None of this study, be it the IRIS, be it the second generation Nilod, Desart versus imatinib studies, they looked into the quality of life aspect of these patients in depthly. So this is one study which was published by the group led by Dr. Hawk Cortes. And they initially, another group, they have proven that patients who are on imatinib and those who got chronic low-grade adverse events, let's say it be a skin rash, it could be a musculoskeletal problem, it could be the periorbital edema, when they are impairing the quality of life, then in this study, this is called as the ENRICH study, they have changed these patients from imatinib to nilotinib, just for the chronic low-grade adverse events, not for the molecular responses. Okay. So let me explain this picture. They have calculated the side effect profile at 2 time points. One it as early as 1 month. The other time point was 3 months. As you could see, when you shift the patient, even though the side effects are chronic and low grade, there is at least in 85% of the patient, close to 90% of the patient, even at one month, there is either no worsening, rather there is improvement on all those chronic low-grade adverse events. And with time, which is the next time point is 3 months, these numbers are increasing. So it is improved in 2/3 of patients. It is unchanged in 1/4. In close to 1 or 2% of the cases, they are worsened. So at least in this study, the group had shown that even though the side effect profiles are not very bad, but you are switching the patients are having a more pleasurable time. The other aspect in US as of today, that this is an old publication, it is in 2013, and by 2013 at least those three drugs were available: imatinib, nilotinib, and dasatinib. This was led by Professor Kantarzian from MD Anderson Cancer Center, and they wrote this piece that the treatment of CML, which is now a chronic disease, is very costly, and it is because of the unsustainable drug prices in CML, and which would be causing indirect harm to the patients, even though the disease is under control. So there was a lot of advocacy for low drug prices to save the lives of patients who cannot afford them. So Novartis, while they were doing imatinib, there was a program, GPAP, now it is stopped. So the drug was available to patients who had socioeconomically poor status. So they got the drug for free. So let's come to our perspective. Now, this was a paper written by one of my colleague, who is Dr. Prashant Ganeshan. So this was a review article, and you could see the median age of patients who present to us in our country, it is 35 years as compared to 47 years in the West. Hardly ever we find patients who have asymptomatic presentation, which is less than 5%, and the asymptomatic presentation in West is 36%. Splenomegaly is 95% in our cohort, it is 60% in the West. If you compare it with the IRIS study, it is 25%. 2/3 of our patients, they had fever or constitutional symptoms, and it is only 1/3 of patient in the West. Sokal low score, it was found in 1% in our cases. It is found in 1/3 in West. Intermediate is 60% and high is 40%. It means a lot. So it means that we are looking at patients who are having a lot of symptoms, moderate to severe, due to CML in our country. Now, this is one piece of a study which was published from our group as an abstract. This was done by my student, Dr. Rinku. And we tried to analyze what predicts MMR at 12 months, which predicts a good overall survival. We took around close to 200 odd patients. Mostly 90% of these patients, they received imatinib. So the MMR rate at 12 months in our retrospective analysis is close to 40%. The interesting part was when we were doing a retrospective chart review on these cases, the mention of Sokal score was not great. I would say it was close to 30 to 40%. So we took out Sokal score from the analysis and we included, most of the time there used to be a picture where the splenic size or the splenic extent was mentioned. So we just measured spleen as per the clinical notes. And in this multivariable analysis, as you could see, the only thing that predicts MMR at 1 year, is the amount of splenomegaly. If the spleen is beyond the umbilicus, we have also analyzed it with the size. We found out the size was 7 centimeter. Those who are not reaching till umbilicus. So patients who had splenomegaly beyond umbilicus had a very poor chance to achieve major molecular response at 12 months. So I also had my own biases over the years. When I was a senior resident, that was not long back, I initially thought it is imatinib is better than dasatinib, nilotinib, bosutinib. Some of it could be economy driven, but the other thing was in a heavy workload, what you do in CML cases is you write them imatinib at 400 milligram OD to take it at night after food and to take it for 4 months and don't come back between 4 months. And this is what we used to do among all the other cancers. CML used to be a lifesaver, but we would not spend a minute more. But as a faculty, I mean, in the early phase, I thought dasatinib is a better drug than imatinib, than nilotinib and bosutinib. And because dasatinib was available as a generic lot earlier than nilotinib and bosutinib, so we had some experience of dasatinib over the other second generation TKIs. But in last 4 or 5 years, I would say my view has changed a bit because of the dasatinib related toxicities that I would have seen in my cases. So now I feel possibly nilotinib is a better drug in our patients. I initially thought nilotinib is more into discipline. The patient had to be empty stomach. So apart from the disease, this fasting is also contributing to the response. And it is not very convenient for patients to be fasting for 6 to 8 hours a day. So I never liked nilotinib, but over last 5 or 6 years, I would say by whatever experience we had on nilotinib, we felt nilotinib could be a better agent than dasatinib, and then imatinib and bosutinib. Now asciminib is available, and I believe it is a far more tolerable agent. We had some experience of using asciminib as a compassionate basis in patients who on the further lines, at least third or fourth line, we have used asciminib. It is a lot better drug than imatinib, nilotinib, dasatinib, I would say. But as of today, the economics drive my decision. So asciminib, I have kept it for future. So while dealing with our patients, a good amount, they are poorest of the poor. So the financial toxicity of these cases, as of today, these drugs are available free of cost to our patients. But there was a time, I think, when GPAP was not available, the only source was they had to pay for the drug. Now, since last 4 or 5 years, we are getting imatinib for free in our hospital. So this is one toxicity I got. This was also an area I focused on after my brief interaction with Dr. Mark Ratton while I was doing an observership at MD Anderson Cancer Center. And he told me something about interventional pharmacoeconomics, where you could use some of this off-label doses without compromising with the efficacy of your drugs. And that was the time. This is one of the drugs that we use in prostate cancer. It is called as abiraterone. Abiraterone was labeled to be used in empty stomach. It was given 4 tablets in empty stomach. And if I say crudely, this drug is not well absorbed in empty stomach. When you take 4 tablets, 3 tablets, they pass through the stool and only 1 tablet, it gets absorbed. But when you use it with food, especially when it is rich in fat, then the absorption, it increases substantially, as you could see in this cartoon. This is empty stomach, and you could see this is high fat and this is low fat. So this was one of those studies that we took up in our institute. We gave patients both 4 tablets in empty stomach, then gave a gap, and then gave 1 tablet with a low fat diet. And this was our results. And you could hardly guess which one is the experimental arm, which is 250 milligram with milk, or which one is 4 tablets in fasted state. So beyond that, our practice, at least in prostate cancer, for patients who cannot afford abiraterone, because it used to cost some 10 to 20,000 a month. So with this, the cost of this drug was reduced by at least 1/4. And that was the time where nilotinib was only available as not available as generics. So this was the second study. This was sponsored by ICMR. This was done by one of my colleague, Dr. Ankur Vashne. And in this study, we tried to look at the nilotinib pharmacokinetics with respect to the food. So this was during the COVID time. We could recruit 40 patients, out of which 30 patients got into the study. You could see here they are all young patients. The hemoglobin is 9, the TLC is close to 200,000, platelet count is 3 lakhs. And most of these patients were well preserved. Low risk was 8 patients out of 27, close to 30%. So here this is a complicated table for those who are clinicians. Let me explain it one by one. In the standard dose, that is 300 milligram BD without food, the AUC was close to 5,000 and the Cmax was 235.8. And when you compare it with 200 milligram BD before food, it was almost the same numbers, 5,000 and 300. Even when you give just one tablet twice a day without food, the AUCs are not different. So in these 3 cohorts, it is very easy to say, at least in our patients, where the weight is a lot lesser than the Western cohorts, you could see there is no increase in the drug pharmacokinetics even when you are using half the dose as compared to 300 milligram BD. But when you are using 150 milligram BD with food, then the AUC is crossing 10,000 and the Cmax is somewhere around 800. It is increasing absolutely by 2 times. So we felt we can definitely reduce the dose and make it more convenient by giving it with a low-fat diet. This is another study which was published from another group and from West, and they found that if you are taking 200 milligram BD with a meal, it is almost as good as taking 300 milligram BD. The methodology of this study is completely different than ours, but nevertheless, it suggests that the doses of nilotinib can be further reduced from a 300 milligram BD empty stomach to 150 or 200 milligram with food twice a day. So the next part was a clinical study to show that the pharmacology, the pharmacokinetics, the food-induced pharmacokinetic optimization, is it superior to the standard dose imatinib? Now, imatinib is our standard of care irrespective of the SOCAL score in our patients. So we did this randomized phase 2 study to look for the superiority of this low dose nilotinib 150 milligram BD with food, whether it is superior to the standard dose 400 milligram OD imatinib in achieving the early molecular response at 3 months. You would have seen that we have planned a randomized phase 2 study, and we have kept the primary endpoint a little simpler, that is EMR at 3 months. It is because this sort of studies are never funded by any of the institutes, any of the granting bodies. So we could only get the grant from institute, which was a limited grant. So we had to modify the study. And again, Indian patients, we know there could be a lot of adherence issues. So when you are randomizing patients into, let's say, 12 months, it is very difficult to ensure that these patients are taking the drug for the whole 12 months, or at least 90% of the time in either arms. But when you are taking the drug for the first 3 months, the compliance rates are still a lot better. So this was done by one of my colleague, Dr. Deepak. And this is the workflow of the study. It was a randomized study of newly diagnosed CML-CP patients into 2 arms. The one arm was 150 milligram BD nilotinib capsules 30 minutes after food, and the other arm is imatinib 400 milligram once daily. There are assessments with respect to all the blood investigations. At 3 months, we assess for the early molecular response, whether it is less than 10% or more than it. the toxicity assessment, we have also analyzed the quality of life of these patients within this study period, that is at baseline, at day 30, and at day 90. So these are the baseline characteristics of the patient. This was 150 patient were randomized, close to 75 in each arm. As you could see, the age is in 30s. The spleen size is 8 centimeter and 6 centimeter. Hemoglobin is less than 10 in either arms. The white cell count is close to 150,000. And the median SOCAL score is 0.93. So let's come to the primary endpoint by ITT analysis. As you could see, patients on imatinib, the early molecular response at 3 months is close to 40%, and in nilotinib it is close to 70%, and the p-value by Fisher exact test was significant. Now, from the previous study where we found that any patient who have a spleen size of more than 70 centimeter or less than 70 centimeter, it is corroborative of major molecular response at 12 months in the previous study. In this study, we also analyzed this part. So patients who have a spleen size of less than or equal to 7 centimeter, in nilotinib arm, close to 90% of these patients, they achieved EMR. With imatinib, it is only 2/3. When it is more than 7 centimeter, the size of the spleen, then only 60% of nilotinib they have achieved an early molecular response, and 20% of the patients in the imatinib arm, they have achieved the early molecular response when the spleen size is more than 7 centimeter. So that is at the, I mean, even if you don't calculate the SOCAL score, because the SOCAL score in West, there are at least 3 types, 30% each of low, intermediate, and high. In India, it is close to 70-80% of our patients are intermediate or high risk. So the SOCAL score is fine if you measure the spleen nicely. Otherwise, grossly, you could see when the splenic size is more than 7 centimeter, using nilotinib is far better than going for imatinib with respect to the early molecular response. These are the non-hematological toxicities. As you could see, the peripheral edema and periorbital edema was more in imatinib. Interestingly, we have also found that rash, which is also more common in imatinib, it is only 4% in nilotinib. The pruritus, it is found more commonly in imatinib. Headache, which is commonly mentioned as a common side effect in nilotinib, was found in 15%, but it is 30% in imatinib. When you look into the grade 3-4 adverse events, anemia were more common with imatinib. Otherwise, the neutropenia, thrombocytopenia, the other pruritus, anorexia, and diarrhea, they were equal in both arms with respect to the grade 3-4. Now, let's come to the impact on quality of life, because now we understand whatever you do, the survival remains close to same, be it first generation, second generation, at least in Western population. So how the patient feels while he is taking the drug for a long term, it is assessed by a quality of life questionnaire. And in this study, we have measured the quality of life by this QLQ CML24 domain. This not only picks up the burden of CML, but it also picks up the toxicities of TKIs. As you could see in all the domains, be it symptom burden, be it impact on worry or mood, be it impact on daily life, be it satisfaction with care, be it satisfaction with social life, it is better with nilotinib. This picture has got a lot of data, but I would say you can consider it just on, let's say, on impact on worry and mood. At baseline, both the arms are similar. At day 30, there is a decline in both, and this is not statistically significant between these two arms. But by day 90, it is better in nilotinib than imatinib. And this sort of pattern has also happened with the body image issues, the satisfaction with care, the impact with daily life, the impact with social life. With respect to the impact on social life, it has improved by day 30, and it was significantly better with nilotinib. So the blue The blue boxes are nilotinib and the red boxes are imatinib. Okay. Now let's come to the CMLCPs, which are the brightest. CMLCP, which have done well for over a very long time, and then we try and stop the drug in those patients. This is one analysis which was published as an abstract and it was published by my colleague Dr. Chetan. And he found out that when you are stopping imatinib in patients who are registered here, I'll be going into the patient details. Patients who have got a late phase BCR-ABL decline, it predicts a far better stopping than the other factors which are mentioned in previously. So this was close to 130 patients. The median age is 30. And when we are looking at the stopped studies, you could see that 1/3 of, all the patients were, if you look into the ELTS scoring, 1/3 is low risk, 1/3 is intermediate, and 1/3 is high risk. As you could see, these are special cases which who have done well. That's why the low risk or the intermediate risk is as good here. The median time to complete cytogenetic response was close to 1 year. The median duration of TKI was 81 months. Now, what is late phase BCR-ABL decline? You would have seen patients where the BCR-ABL with every visit, with every measurement over 3 or 4 months, there is a continuous decline. And in this analysis, we have put these patients into 3 groups based predominantly on the late phase BCR-ABL decline. Patients who have got a nice BCR-ABL decline, which is late phase, they tend to do well. There are no failures, they are low risk. And when there is a very bad decline or there is no decline, most of these patients have actually relapsed. And there is also an intermediate group. So the question here is, what do we mean by the late phase BCR-ABL decline? Now, if you remember this curve, there is a first slope here which declines rapidly, and there is a second slope here which declines very gradually. So this first phase is mainly due to inhibition of CML cell proliferations. And the second slope could be due to inhibition, but I would say there is more influx of immunomodulation because of the TKIs coming here. That's why there is a continuous late phase decline in these cases. And these are predictors for a better stoppage of imatinib. So TKIs are not just anti-proliferative agents, they are also immunomodulators. And the best example here, I would say, it comes from dasatinib, where things are very, very eye-catching. You would have seen patients who are on dasatinib, their neutrophil, it goes down, the lymphocytes, it come up. If you look at these lymphocytes, they are actually large granular lymphocytes, either of CTL or NK cell origin. Patients who have these lymphocytosis, these patients, they have a higher chance of achieving molecular responses. But at the same time, these patients have a higher chance of immune-related adverse events like pleural effusion, diarrhea. There are many more. We have seen cerebellar toxicity. We have seen many sort of this immune-related side effects, severe headache. So dasatinib could be the best immunomodulator, but it possibly breaches the time. Breaches the line where it produces the benefit, and it could be more harmful, especially when it is producing some troublesome pleural effusion or diarrhea over long term. And I have seen in my clinical experience, these diarrheas, when these patients are on dasatinib and they visit a gastroenterologist, they tend to classify these diarrheas as inflammatory bowel diseases, and they do not respond as well to the IBD therapies here. So the best immunomodulator that is available, which has got a good balance, is possibly nilotinib. It doesn't cause this pleural effusion or diarrhea to the same extent as dasatinib does. So this is one of the study where this is called as a petal study. This is just recently, published a month or two back by the French group, and they believed that nilotinib is possibly a good immunomodulator with which interferon alpha could still be added. The primary endpoint of this study was MR 4.5, and as you could see, patients who received both nilotinib and interferon alpha, they had a higher chance of MR 4.5 of 24% versus 15% when they received nilotinib alone. But we understand there are toxicities relating to an interferon. The quality of life analysis was still not there in this study. But if these patients are to be planned for a TFR, then this could be a nicer agent to add in patients who could tolerate it. And this interferon alpha was pegylated interferon alpha here. In this study, they have not looked for the stopping studies. What happened in patients who were stopped the treatment and what has happened to the durability of the remission. So in the next 5 minutes, I would discuss what are the future directions that we are looking at here at AIIMS. Now, all the cancers have got hallmarks. There are many cancers which are got very specific hallmarks of cancer. There are cancers which are mainly moved by immune escape, let's say. You would see that example in Hodgkin lymphoma, and the best drug is nivolumab. In a fraction of patients, you would see that even when these patients are relapsed and refractory, when you use nivolumab, they go into complete metabolic responses very nicely without any toxicity. So there could be a subgroup of Hodgkin lymphoma which is curable just by immunotherapy and no chemotherapy. It is to be proven in future. It is just like a solid cancer called as melanoma, which is having the hallmark as immune escape. If you are making them immune proficient, these cancers are getting cured. There are other examples. For CML, the three hallmarks which are important is the sustained proliferative signaling. It is through the BCR-ABL1 signaling. The second is genome instability and mutation. As of today, you could call a good fraction is going to the concurrent ASXL1 mutation in CMLCP. They could be having genome instability. Many of these patients with other mutation apart from ASXL1 or cytogenetic abnormalities, some specific cytogenetic abnormalities could come into this genome instability. These patients are technically CML who are in accelerated phase. And in the third, there is avoiding immune escape. Immune escape could be avoided even in very early stages of CML. CML remains a very immunologically cured hematological malignancy. When you look into the previous studies of bone marrow transplantation, you would see patients who develop GVH, especially patients who have CML who develop GVH, their cancers are more likely to be cured, especially when the GVHD is chronic GVHD. The same amount of curability, it doesn't happen with AML or ALL. So immune escape avoidance by CML, it also has to be diagnosed nicely because these are the patients who could be more sicker. These are the patients who might present with accelerated phase of blast crisis, who would require, apart from TKI, if they are not responding nicely, some other immunological maneuver like BMT. So this is one of the future directions that I'm looking at, how to clear CML through immune-mediated approaches. Now we all know interferon is not an easy drug to be done in these cases. You have to understand in India, the CML cases, they are in 30s, especially when there is a mass sibling donor available because BMT is nowhere in picture in the bigger guidelines. It is only used in the later stage. When you reserve BMT for a very later stage, the complications can actually also go up. So you have to use this this intervention a little more nicely, in which could be possible in few of our cases, especially when these TKs are not able to do immune clearance of CML, when they are not achieving good molecular responses, they are hematologically intolerant, especially patients who are imatinib poor responders. We still do not have a data from our country where imatinib is the most common agent in more than 90% of the cases. I would say 95%. What happens in patients who respond poorly to imatinib, be it a molecular response or be it them hematologically intolerant? What happens to their survival? So now the second aspect that I am focusing right now is what are the role of cytogenetics or next generation sequencing in personalizing treatment in patients of CML in our hands. So this is the cytogenetics of one of the cases. She is a close to a late 30 lady who presented with CML-CP with high Sokal score. And this was the cytogenetics. As you could see, here there is a translocation. It is a balanced three-way translocation between 9, 22, and 20. Now, when you look into the literature for these patients, this three-way translocation, they actually do not portend that bad a prognosis. Now, one of my friends at my OPD, he also sent this patient's NGS. Now, this is the NGS which was done at baseline. As you could see, there is a BCR-ABL1 fusion, and there is an ABL1 non-P loop mutation from F317L. Now, this mutation, it confers resistance to imatinib and dasatinib, followed by dasatinib, and nilotinib could be considered. Now, this patient had Sokal high risk. As of today, both imatinib and dasatinib at our hospital is available free of cost. This patient was started on low dose dasatinib of 50 milligram because we feel that starting these patients on a high dose could be tricky. This patient had moderate symptoms because of dasatinib, and 3 months this patient didn't achieve EMR, and that was the time point when we changed the patient on to nilotinib at 150 milligram BD that we practice here. And this lady, she achieved major molecular response by 6 months. So these sort of things are also possible. I mean, when you know your patients in depth, you could actually treat them a little more nicely. Otherwise, it should be okay, but on a long run, we are not sure whether we are pushing these patients to more bad outcomes. Now, this is the next future direction that I am concentrating right now to understand the stages of CML with respect to the hallmarks that I have discussed. So there is this CML who are CP. Can we diagnose? I mean, those who are CML are nicest CPs are the cases who are achieving all the milestones, who are achieving the TFR eligibility. And let's say if you are stopping the drug, in 50-60% of these cases, they are retaining it. Let's say if these patients relapse at a second attempt, let's say 20% more. So this CP-CML, which attains all the milestones, have good immunomodulation, this is the CML that I am going to call as chronic phase. Rest of it is possibly, it is CP plus, where there is more genomic instability and clonal evolution. We need to understand, as of today, there is a lot of literature which is coming around ASXL1. Now, having ASXL1 puts this patient at an excessive risk of having the mutations and non-achievement of molecular responses, and these are the patients who might actually require a bone marrow transplantation. Even the newer drug that is asciminib, it is not effective or maybe worse in patients who have concurrent ASXL1 mutation. And also understanding the blast crisis phase, even when the blast percentage are not crossing 20%, with respect to the multiple high-risk mutations, profound immune escape in these cases, because these patients are not going to be, I mean, with the TKIs, the immunomodulation is not going to give them a good long-term cure. These patients are to be identified at the baseline and to be planned for a BMT a little earlier than later. So to conclude my presentation, in our experience, CML is younger patients. They are 30s. We still do not know what is their biological age. Maybe these patients are at an accelerated aging. That is one of the research idea I have. They are symptomatic with heavy burden with a large spleen. They have B symptoms. They also have anemia. So it would be wise to identify them well. A second generation TKI like nilotinib at a lower dose with food could be giving us better results and better quality of life. We didn't do a cost-effective analysis to tell you that it is cost-effective. At least for patients who have got a more than 7 centimeter spleen, avoid first generation, which has got only 20% chance to achieve an early molecular response. Watch out for the patients who are poor responders to TKI. This remains an unmet need, and these are the patients where more focus should be given. The quality of life, these patients, they come to our OPD, we do not mind having them the low-grade toxicities. It impairs their quality of life. Allow them a switch. Maybe nilotinib could be a better agent here. And I would suggest we need to have a more population-based data to make far more guidelines with respect to what should happen to the TKIs. Let's say if a patient is not responding to imatinib, what should be the next step around? What is the role of BMT in patients who are 30s or 40s? So that should be cleared. That is my last word. And before I end my presentation, today is Rath Yatra. This happens in Puri from Odisha. This is the place I originally belong to. And I'll be happy to answer a few questions if you have.
Thank you, Ranjit, for this thought-provoking lecture on CML. I was looking forward to a lot of innovative ideas, and you didn't disappoint. You told us what all you did at your center, and you also told us about at least 3 of your future plans. So congratulations.
Thank you, sir.
Always kept everybody alert, and it's wonderful to keep listening to you all the time. Nothing is duplicate, it's innovative, and that's always how Ranjit is defined. So questions please for Ranjit. We have about 8 minutes to go. There's a question in the chat box. What subgroup of CML patient will you recommend upfront NGS testing?
As of today, an NGS is costing 10 to 12,000 with cytogenetics being done free at our center. So I would say for everyone, I would suggest an NGS.
Another question. If a patient has blast crisis of CML, do you think that addition of chemotherapy with the TKI as against stem cell transplantation is better? Newer TKI plus asciminib followed by stem cell transplantation without any chemotherapy induction?
Okay, so this is a very nice question. I would say this question is leaning towards lymphoid BC. So if it is a lymphoid BC happening in the background of CML, the problem is in the lymphoblasts. So when you do a lot of chemotherapy in the background of CML, these patients can become very sicker. So it is always wise to use the best TKI upfront. If at all, you can add another TKI like asciminib in combination, plus steroids, some VCR. That will give you a complete hematological response to 90%. Now it is seen, I mean, those patients who have got pH positive ALL, CML with lymphoid BC, patients who have technically CML lymphoid BC, they tend to become sicker with intense chemo. So it is wise to identify these cases if it is a lymphoid BC. So for lymphoid BC, my go-to is to use a second generation or a third generation TKI with steroid and VCR. Get them into CHR and then look at what is happened to the flow and then decide the further treatment. For myeloid BC, the regimen which is mentioned is use a second generation TKI or a third generation TKI with chemotherapy. Now, chemotherapy in our hands, the mortality rates are close, I mean, they are in double digits. So what we do is we tend to do TKI first, And we have also done some combination TKIs. They are very tolerable, and it is very early to tell that whether it is effective than a single TKI. But because these patients are sicker, so it is wise to use the best TKI or TKIs upfront, with or without chemotherapy for myeloid BC. That is the way we go about here.
Thank you. As the goal of treatment of CML-CP has shifted from survival to making the patient functionally cured and get off the drugs and not relapse. So any thought from that angle that how can Indian patients achieve that to the highest number of patients? What should be the strategy in India?
So this is a good question. Uh, if you look into the CMLCP, the stoppage trials, you have to look at the BCR-ABL kinetics. That is what we have found, that beyond, if the patient is continuously declining to very low levels, they have the finest chance of achieving TFR. So apart from that group where we have maintained the TFR to close to 80-90%, apart from that group, I would say if the patient is on first generation and the patient is closer to MR 4.5, you are still not decided what to do. The next best thing is, there are two ways here. First is reduce the imatinib dose to 200 and don't stop it rapidly. And on 200, if the patient is maintaining the same thing for a close to 1 year, then attempt a stoppage. The other direction is to use a second generation or a third generation TKI. These data are coming up. You give the second generation or third generation TKI as a consolidation in these cases for close to 1 year, and then you attempt a stop. It could be more successful to achieve a TFR in such cases. So they are my suggestions.
Right. So almost for 1.5 decade, we talked about TFR of 50%, and it remained a mystery that why those 50% of patients you are not able to achieve TFR.
Yeah.
Now it appears that if you have this sustained 4.5 and keep it like that for 5 years or more, then this percentage can go up significantly.
Yes. Yes, sir. I completely agree.
So depth and duration.
Yeah.
Maybe we can take one more question. There are 2 minutes. Is there any point in targeting leukemic stem cell, targeting tumor environment, epigenetics after achieving the TFR?
That is a good question. Um, so most of the TFR failures that you are going to have is because of persistence of leukemic stem cells. There had been attempts at this place of using pegylated interferon, and it is only mildly successful. So till this time, we do not have enough drugs to take care of the immune control, to make them more immunologically cleared apart from BMT. I mean, because BMT is one shot, and as we are approaching a non-relapse mortality of less than 10%, the option of BMT will come up in future, especially in those patients who are not achieving TFR, where there are more tests to diagnose that these leukemic stem cells are still there. There are no other way to diagnose that these stem cells are there other than doing an RT-PCR if they are still there at a very low level. And there is some information which is now creeping up, not by just monitoring RT-PCR. If you are doing a proper high-depth myeloid NGS, if you are looking at other mutations which are there, if those mutations are there, then the chances of TFR could be a little lesser, but those data are yet to mature. So it is a nice question, but I do not have an answer or option for this.
Thank you, Ranjit. I wish we had more time and we would have gone on asking you questions and keep listening to you. But now rest will be for some other time. Extremely grateful to you for sparing your time and giving
Thank you
this
very much, sir. Yeah.
lovely summary of the work done at your center and your future work that you're planning to do. Thank you. So we'll move on to the second part of our webinar. I'll just share and introduce our next guest speaker. That's our international guest speaker. So we're Dr. Cami Maddox from USA. We have heard her multiple times in past, and I'm extremely grateful to her that she spares her valuable time to educate us in this part of the world. Briefly, she's professor, clinical internal medicine, director, lymphoma program, chief medical officer, Arthur James Cancer Hospital and Richard Solovo Research Institute, the Ohio State University Comprehensive Cancer Center, Associate Division Director for Ambulatory Operations Division of Hematology, Ohio State University College of Medicine, Chair Clinical Scientific Review Committee, Columbus, Ohio, US. A lot of things to handle. She is an expert in the field of B-cell malignancies, lymphomas, and CLL. Her research areas include evaluating new targeted therapies for these disorders. She serves on the Alliance Lymphoma Committee, a multi-institution working group to develop clinical trials in lymphoma that can be done across several institutions, and she is Alliance Chair on 2 mantle cell lymphoma trials. Her group was awarded to study functional genomics in mantle cell lymphoma therapy and mechanism of resistance. She enjoys interacting with and treating patients and has received a Patient Satisfaction Award over the past several years. Today, she'll be speaking to us on a case-based discussion on management of MCL in 2026. I'll stop here and hand over the platform to Dr. Kevin.
Thank you, Dr. Agarwal. Let me see if I can just. This isn't letting me share. Can I have access to share?
Kalpesh, can you help him?
Zoom isn't letting me share my slides.
Sorry, pardon?
Permission to be
It is
granted.
there, sir. Permission is there, sir.
Permission is there.
There
Okay.
is no restriction. There is a green color button at the bottom.
Do you know when I click on share, it's not letting me?
Ma'am?
Yeah. This is not letting me share my slides. I just emailed them in case you can share them.
I'm just putting my email ID on chat box, ma'am.
Yeah, you put your email ID in the chat box. You will.
Ma'am, it is
Oh,
there.
okay. I think I already emailed them. sent them to the email that sent me the Zoom link. Yes, did you get them?
Kalpesh, you got the slide deck?
Yes, sir. I'm downloading.
You got it. So, yeah. Okay.
Yeah, yeah.
Okay.
Okay, great. Thank you. So I'm going to do a case-based discussion on MCL treatment in 2026. Next slide. These are my disclosures. Next slide. So I put together 4 different cases, and I focused on frontline because I thought that this frontline discussion would actually probably take up our time. So let's go to the first case. Next slide. So this is a 73-year-old male farmer who presents with a history of hypertension, hypercholesterolemia, diabetes controlled on oral medication. He presents with fatigue and unintentional weight loss. On exam, he does have palpable adenopathy. His labs show a hemoglobin of 8.8, a white count of 15,000 with circulating lymphocytosis. Platelets are low and LDH is elevated. His PET scan shows diffuse lymphadenopathy, splenomegaly, and a renal mass. He has a biopsy that's consistent with classical mantle cell lymphoma by histology. The Ki-67 is elevated at 40%. Molecular testing is done, and sequencing does not show any TP53 mutations. Next slide. So we have a 73-year-old gentleman, stage 4 MCL, some comorbidities, but high risk disease. So thinking about treatment options for this patient, what would be the recommended treatment? Next slide. So the frontline treatment for older patients with mantle cell lymphoma has evolved over the past few years. So, historically, the standard has been to use less intense chemoimmunotherapy in this patient population with regimens such as bendamustine, rituximab, R-CHOP, VRCAP, and then use, in many situations, rituximab maintenance. So the use of BTK inhibitors, which are approved in the relapsed refractory setting for numerous years, has really changed the practice for mantle cell lymphoma, and a lot of effort has gone into bringing these into frontline trials. So the first attempt at this was really the SHINE trial, and this was a large randomized double-blind phase 3 trial that took patients in this patient population, like our patient in the case, 65 years and older, not considered candidates for stem cell transplant with stage 2 to 4 disease, and randomized them to treatment with what was considered standard treatment with bendamustine rituximab for 6 cycles followed by rituximab maintenance, versus that standard treatment in combination with the BTK inhibitor ibrutinib. The primary endpoint of this trial was progression-free survival, with other efficacy endpoints as secondary endpoints. Next slide. So this trial was a positive trial. It met its primary endpoint. The addition of the BTK inhibitor ibrutinib improved progression-free survival over that of bendamustine rituximab with rituximab maintenance alone, increasing the median PFS by a little over 2 years. If you look at the overall response rate and the CR rate between both arms, they were actually fairly similar. Next slide. However, this, or if you look at the PFS in the high-risk subgroups, which was blastoid pleomorphic, TP53, there really wasn't a significant difference. Early on, it seemed that there might be, but there was no benefit to the BTK inhibitor in these high-risk subgroup populations of patients. And the trial wasn't designed to detect a difference in these populations, and there were small numbers, but nevertheless, there was hope that this would be a population that benefited, and it didn't in this trial. Next slide. So what we saw with this trial is that there was no difference in overall survival, but it again was a positive trial and a benefit in progression-free survival. But when it went to the initially went to be reviewed by the FDA for approval in the frontline setting, there were a lot of concerns that came up about the toxicities. So while there was a benefit in progression-free survival, there was no benefit in overall survival. And when they looked at deaths, there were more deaths due to disease progression in the standard arm, the BR placebo arm. But there was a higher rate of treatment-related deaths, particularly related to infection in the BR with ibrutinib arm. You can see there was also significant increases in what was considered BTK-related toxicities, including bleeding and atrial fibrillation. So ultimately, the concerns from the toxicity of this combination led to the company withdrawing its application for use in the US for mantle cell lymphoma. Next slide. Again, overall survival, no different with over 7 years of follow-up and similar in both arms. Next slide. So while that study did not lead to a frontline BTK inhibitor approval, there was a second study, and this was the ECHO study, and this was very similar to design to the SHINE study, but used acalabrutinib. So why would this be any different? So acalabrutinib and zanubrutinib are second generation BTK inhibitors with more specificity for the target. So they have less off-target kinase inhibition, which was theorized to cause less side effects or less toxicities. And we have seen in randomized trials, not in mantle cell, there's never been randomized trials in mantle cell, but in CLL and Waldenstrom's, that single agent trials have shown that the toxicity profile of the second generation BTK inhibitors was improved over that of ibrutinib, including less cardiac toxicity and less bleeding risk. So the ECHO trial was really designed to ask the same question as the SHINE trial, with the same idea of adding a BTK inhibitor to the BR, but with what was felt to be a safer BTK inhibitor. So this trial was the same patient population, 65 and older, with mantle cell lymphoma, not considered candidate for autologous stem cell transplant, randomized to essentially the same 2 treatment arms, except for using acalabrutinib instead of ibrutinib, with the same primary endpoint of progression-free survival. Now, one notable difference in this trial was also that this trial did allow crossover. So for patients who progressed on the standard arm, they were allowed to cross over and receive BTK inhibitor on trial in the second line. So, potentially more access to early BTK for those that were progressing. Next slide. So this trial was a positive trial. The primary endpoint was significantly improved with the addition of acalabrutinib to the BR with rituximab maintenance regimen. Now, if you look at the median PFS overall in both arms, it's shorter than what we saw in the SHINE trial, but that's because there was not, when this data was initially presented, the follow-up wasn't as long for this as it was for the SHINE trial. But improvement in progression-free survival by about 17 months, same reduction in risk of progression or death. Now, what's notable is 70% of the patients that progressed on the standard arm did receive BTK inhibitors as a second-line treatment. Next slide. The overall survival with the current follow-up was no different in this trial either. There is some question if the availability of the crossover and the second line BTK inhibitor could play into that. Next slide. Now, this trial, we're going to look specifically at patients with high-risk disease features. So in this trial, they considered patients with high-risk disease, and they defined that by either the high-risk MIPI, having a TP53 mutation, having a Ki67 index greater than 30%, and or blastoid or pleomorphic histology. And they showed that the addition of acalabrutinib, in fact, did improve the complete metabolic response rate in this high-risk patient population over that of the standard arm. So overall response, you can see, was fairly similar across both arms in the high-risk population. And really with the overall population. But the complete response rate increased from a little under 52% to approaching 70% with the addition of acalabrutinib. Next slide. Now, there is some, controversy when we think about using, not controversy, but when we think about defining mantle cell lymphoma in a high-risk patient population, many patients in this category are high risk by MIPI because age is one of the categorical variables that's used in the MIPI. So that does tend to be this patient population tends to fall in that higher risk anyway. But when we think about biologically high-risk characteristics, so disease that we know does worse because of the biology of it, so those with TP53 mutations, high Ki67 index, or blastoid or pleomorphic disease. So they looked at outcomes in just this high-risk patient, biologically high-risk population, and they showed that indeed the addition of acalabrutinib did provide a longer progression-free survival in patients with high-risk disease with a median PFS of 3 years to 50 months with the addition of acalabrutinib. So if we go back, and then ultimately in this trial, what they showed is that the safety, there was not the safety concerns. While there were some higher incidents of some safety events with the acalabrutinib, there was not the concern that there was with the SHINE trial. And so this has led to a frontline approval here in the US by the FDA of acalabrutinib in the frontline setting in combination with bendamustine rituximab. I don't use this in all patients. There's still questions if you can sequence, BR, then second line BTK versus using BR plus BTK. But in the patient that I presented, where that patient is a high-risk patient, remember their Ki67 was 40%. So in patients who have higher risk biological disease, such as high Ki67, I have incorporated this regimen with acalabrutinib in combination with the BR and then rituximab maintenance for the frontline treatment of this type of patient. Next slide. Okay, so let's move on to our second case. So we're going to stay in the realm of the older patient population. These again are patients who historically have been treated with chemoimmunotherapy and not considered candidates for autologous stem cell transplant. So now we have a 78-year-old female, retired teacher, pretty healthy, but does have a history of hypothyroidism, provoked DVT, presents with palpable adenopathy. So her labs show a mild anemia, normal white count, normal ALC and platelets, and actually normal LDH. Her PET scan shows diffuse adenopathy, including an 8-centimeter retroperitoneal mass with some mild splenomegaly. Her biopsy is consistent with classical mantle cell lymphoma histology, no blastoid or pleomorphic histology, and her Ki-67 is 25%, so a little more favorable. She has NGS testing that also shows no TP53 mutation. So next slide. So here we have a 78-year-old female, relatively healthy, stage 4 disease, 8-centimeter mass. So it's not somebody that we can observe because of her tumor, because of the amount of tumor burden she has, but no real high-risk features, no blastoid disease, no TP53 mutation, not considered high Ki-67. Next slide. So again, the standard in these patients has been chemoimmunotherapy with a less intense treatment regimen. The ENRICH trial challenged the use of chemoimmunotherapy in this patient population against that of immunotherapy and targeted therapy. So using BTK inhibitor in the front line, but not in an approach that combined it with chemoimmunotherapy. So this trial enrolled patients, this trial was fully conducted in Europe, enrolled patients who were 60 and older with mantle cell lymphoma in need of treatment, not considered fit for stem cell transplant. And this randomized, so there were kind of two different parts to this. It randomized patients to chemoimmunotherapy versus RBTK. For the chemoimmunotherapy portion, patients could either be treated with R-CHOP or R-bendamustine, so it was investigator's choice. So they were essentially randomized to R-chemo or R-ibrutinib, and then treated with the chemo that had been already chosen by the investigator. Ibrutinib and rituximab was given for 2 years, and then the ibrutinib was continued until progression. Next slide. This trial, again, was conducted all in Europe. When you looked at it, about 400 patients are enrolled. Now, what becomes important, close to 3/4 of those patients were treated with the bendamustine rituximab regimen, whereas about a quarter were treated with R-CHOP chemoimmunotherapy. Next slide. So this was a positive trial when you looked at the median progression-free survival, which was the primary endpoint. The median PFS was improved with the use of RBTK over that of R chemo, with the median PFS improved from 42 to 65 months. Now this was included all patients. Next slide. When they evaluated it by chemoimmunotherapy regimen, it did seem that the benefit of the RBTKI was really driven by the patients who were treated with the R-CHOP chemoimmunotherapy. So the 5-year PFS of IR versus R-CHOP was 50 versus 20%. Next slide, when you look at the progression-free survival for that, the patients were treated with bendamustine, it looked like it was fairly similar. So the 5-year PFS was a little over 50% for the RBTKI and a little under 50% for the BR. So not superior to chemoimmunotherapy, but appeared to be driven mostly by R-CHOP, whereas the argument here is, BR is more commonly used, and it didn't show that it was superior to BR, but it did show that it had similar outcomes to that of BR and just different toxicity profiles. Next slide. When you look at the subgroup analysis from this trial, it did appear that there was benefit in terms of the BTKI rituximab over that of all chemoimmunotherapy, again, in all subgroups except for those with blastoid disease. So this trial, also showed that for patients who have high-risk disease features, particularly things like blastoid disease, that RBTKI is not enough to sufficiently treat them. Next slide. The overall survival was no different in this arm. Next slide. So again, that gave us an option or gave us data to say that the RBTKI is potentially just as effective as chemoimmunotherapy in terms of bendamustine rituximab. Now, at the time that this was presented, there was a trial ongoing called the Mangrove study this was actually an international trial. And this actually tried to answer the question that the Enrich trial answered with just BR. So RBTKI versus chemoimmunotherapy, but only BR, multi-center randomized trial. This was for patients who were not eligible for autologous stem cell transplant, randomized 1-to-1 to standard treatment with BR versus zanubrutinib and rituximab, with zanubrutinib monotherapy continued until progression. Now, I think the important things to note as we think about how this trial ends up reading out are that there was no rituximab maintenance in this, and the primary endpoint is progression-free survival. So one could argue that, this arm treated patients until progression, and this didn't even give rituximab maintenance, which is considered the standard and could, interfere with progression-free survival. The other thing to note is from the Enrich trial to this trial, kind of like we saw from Shine to Echo, is that what's considered, a better tolerated BTK inhibitor was used. So while we saw in the Enrich trial that there was a benefit of our BTKI over chemoimmunotherapy, but it appeared equal to the BR, the question really is that was with the use of ibrutinib, which we know has more toxicity. If you used a better tolerated BTK, could you see better outcomes? So this trial has not been presented, but just within the last 2 to 3 weeks, the company has put out a press release that this was a positive trial and that the RBTKI, the Rituxan zanubrutinib arm, significantly improved progression-free survival over that of BR. Now that's just a press release. We have no data. Hopefully we will see that at ASH. But I think that when you take this along with the Enrich trial, you have data to support the use of RBTKI in the frontline treatment of mantle cell lymphoma. And in my preference is in the patient like I presented, so an older patient, relatively healthy, but low risk disease, but in need of treatment, I offer them the RBTKI therapy. Next slide. So I just want to touch on another study looking at RBTKI in the frontline setting to kind of discuss 2 important points about this. So the Altamira trial was a trial that looked at rituximab and acalabrutinib in newly diagnosed mantle cell lymphoma. So this was for older patients or 60 or greater considered not eligible for autologous stem cell transplant. So this trial did a few different things. One, it stratified patients by high-risk disease. It then treated patients with rituximab and acalabrutinib for at least 12 months. For patients who achieved a complete response and achieved a molecular remission by having negative measurable residual disease at a level of 10 to the -6, they were allowed to stop acalabrutinib and continue rituximab for up to 3 years. So it was an MRD-based approach. However, the MRD-based approach was not used in all patients. It was only used in patients with low-risk disease. So patients who had high-risk disease biology, either by TP53 mutation and or blastoid histology, were continued on treatment indefinitely, regardless of whether they achieved undetectable MRD. And the primary endpoint of this trial was progression-free survival. So next slide. So looking at this, the 12-month PFS of this regimen was 90% with a 2-year PFS of 75%. Treatment was stopped in half of the patients with low risk disease who achieved undetectable MRD. So, this is time-limited BTKI therapy with pretty decent progression-free survival, although we don't have long-term follow-up. But what this trial also showed, so it showed, proof of concept for that MRD directed therapy. But they also showed that there was a striking difference in outcomes in those with low-risk disease versus those with high-risk disease. And that was despite the fact that patients with high-risk disease were continued on therapy indefinitely. So when you look at the low risk versus high risk as defined by the TP53 mutations and blastoid disease, the low risk patients had a 2-year PFS of 91%. So the majority of patients maintained their response, with the high risk patients having only about a 30% 2-year PFS. Next slide. And then when you look at it by include KI 67 of greater than 30%, those patients, that makes more high-risk patients, but their PFS was still only like 38%. So what this trial showed is, one, that, in low-risk patients, it's reasonable to think about a future with MRD-directed therapy. But in high-risk patients, our BTKI alone is not sufficient to overcome high-risk biology, and that we really need to think about, if we're using BTKI in the frontline setting in these high-risk patient populations, that it has to be combined with something more than just CD20 antibody. Next slide. Okay, so that brings us to case number 3. Now we're going to pivot and go to a younger patient who historically would be considered for a different type of therapy. So now we have a 48-year-old male lawyer with an unremarkable past medical history, presents with a 25-pound weight loss, night sweats, palpable adenopathy in the axillary area. Patient has a hemoglobin of 10, white count of 7, ALC is normal, platelets are normal, LDH is elevated. PET shows diffuse adenopathy above and below the diaphragm, splenomegaly, hepatomegaly, and a colon mass, so extensive disease. Biopsy here is consistent, though, with classic mantle cell lymphoma, and Ki67 is 30%. This patient has no TP53 mutation. Next slide. So we have a 48-year-old gentleman, relatively healthy, pretty extensive disease. Historically, this is a patient that we would have treated with intensive chemoimmunotherapy and consolidated the patient with an autologous stem cell transplant. So the question is, in the last few years, has that practice changed, and how has it changed? Next slide. So the first trial I'm going to highlight here is the Triangle study, which really has changed our approach in this patient population. So this was a trial that was, again, conducted all in Europe. This was a trial conducted in younger patients who were considered candidates for autologous stem cell transplant consolidation, with the primary outcome of failure-free survival. So this trial randomized to 3 different arms. What was considered standard treatment at the time, which was R-CHOP, alternating with R-DHAP for a total of 6 cycles, followed by autologous stem cell transplant consolidation. Added, the question asked, did the addition of BTKI to that treatment improve outcomes? So it added BTKI to the chemoimmunotherapy and then gave it for 2 years of maintenance. And then could you eliminate transplant with the use of BTKI? So they gave BTKI with the chemoimmunotherapy and for maintenance, but eliminated the transplant. Now, it's important to note that we're talking about maintenance after transplant has become a standard treatment approach that became standard about halfway through this trial. So they did add rituximab maintenance here along with the ibrutinib maintenance, but the rituximab for 3 years, and about half the patients or an equal number in both arms achieved that. Next slide. So this trial was initially presented with a median follow-up of 31 months, and this was a positive trial. So the addition of ibrutinib improved the failure-free survival over that of standard chemoimmunotherapy. The trial was really set to show that the auto arm, if it was or was not superior to the ibrutinib alone. I don't think they anticipated that there would actually be better outcomes with the elimination of autologous stem cell transplant in the use in favor of the use of ibrutinib. But the addition of ibrutinib was superior to the auto, and the auto was not superior to ibrutinib, and in fact the addition of ibrutinib improved the failure-free survival over that of the standard chemoimmunotherapy. Next slide. At the initial follow-up, there was not a difference in overall survival. Now, this data has since been presented with longer follow-up, and as you can see, it continued to show that both arms that contained ibrutinib performed better than the standard arm with autologous stem cell transplant, and they really performed fairly equally in terms of failure-free survival. So the ibrutinib arms had a 4-year FFS of over 80%, with the standard arm having a 4-year FFS of 70%. Next slide. Further, the 4-year follow-up showed that there was actually an overall survival benefit to the ibrutinib-containing arms, with a 4-year overall survival of a little over 80% for that with a standard arm with transplant, and an overall survival of 88 and 90% for the ibrutinib-containing arms. So, with the initial presentation and now with the longer follow-up, my practice had been to remove autologous stem cell transplant from patients in the frontline setting, should they have access to ibrutinib or a BTK inhibitor. We tend to use the second-generation BTK inhibitors in lieu of the ibrutinib BTK inhibitor. But I think that, this trial showed that for patients where they have access to BTK inhibitor for the frontline setting, that there's not benefit to autologous stem cell transplant. Next slide. Now, I think, the question that does still remains is, what about for patients with high-risk disease? So when they looked at the high-risk patient population, so the auto transplant plus ibrutinib was not superior to the ibrutinib, but there did seem to be a trend. So statistically, there was no significant difference, but there looked like there could be a trend towards benefit in high-risk patient populations of having the auto with the BTKI. Again, my practice has changed to not use autologous stem cell transplant, including in high-risk patient populations, because this showed that it added toxicity, and at the current time, there's no statistically significant benefit. But I think there's still an argument, at least some people believe, that there's still a role for transplant, even with BTKI in this high-risk patient population. So if you go back to our patient, however, they really were not, it was a patient with advanced stage disease, high-risk MIPI, but not high-risk biological disease. And so that's a patient where I would favor a triangle-like approach with the use of BTKI, but not with consolidation transplant. Next slide. So then I want to also highlight a second transplant trial because now all patients have access to BTKI in the frontline setting. So the 4151 trial was a trial conducted all in the US, and this also evaluated the role of transplant, but this used an MRD-based approach. So this was a randomized phase 3 trial that evaluated autologous stem cell transplant and maintenance rituximab versus maintenance rituximab alone in patients who achieved undetectable MRD after induction. So these patients were allowed to be treated with any induction. So it was not dictated. So there was different chemoimmunotherapy used. And then they were tested for with PET and MRD. So for those patients who had evidence of disease, both by detectable MRD or still had disease on PET, they all went to auto and rituximab maintenance. But for those patients who achieved a PET complete metabolic response rate and were MRD negative at a rate of 10 to the -6, those patients were randomized to either receive consolidation with autologous stem cell transplant followed by rituximab maintenance or rituximab maintenance alone. And really the rationale for this trial is that we know that for patients who achieved MRD undetectable states prior to going into transplant, that they had improved progression-free survival after, and for those who the transplant put them into, they have improved progression-free survival. So the question really is, are those patients who you achieve that deep molecular remission going into transplant really in need of that intensive therapy? Next slide. This trial, so when you looked at progression-free survival in this trial, there was actually no benefit to the transplant. So the 3-year progression-free survival for patients who received autologous stem cell transplant plus rituximab maintenance versus rituximab maintenance alone, if they were undetectable MRD, 3-year PFS was nearly identical, 76.6 versus 77.4. No benefit to transplanting these patients who were in an undetectable MRD at a rate of 10 to the -6. Next slide. There was an overall survival benefit. So with a median follow-up of 2.7 years, the overall survival was the same. So 1.1 versus 82.7. So no benefit to the transplant again in terms of progression-free survival or overall survival. And the primary endpoint of this trial was actually overall survival. Next slide. So that shows that even for patients who don't have access to a BTK inhibitor, there's still a potential, the majority of patients are not going to benefit from an autologous stem cell transplant. So 80% of patients had achieved an undetectable MRD going in the trial and were randomized to transplant versus no transplant. So if the patient does not have access to BTK or is not treated with the BTK and you use MRD and they're still positive, then I would say that's the one, situation where patients still seem to benefit from autologous stem cell transplant. This is case 4. So now we have our last case. This is a 62-year-old female with a history of depression who presents with abdominal fullness, anorexia, and weight loss. So symptomatic disease, she has circulating disease with anemia and thrombocytopenia. LDH is mildly elevated. PET shows diffuse adenopathy and splenomegaly. Biopsy is consistent with mantle cell lymphoma. It's classical, not blastoid, but the Ki67 is 50%, so it's higher. And when NGS is sent, this patient actually is found to have a TP53 mutation. Next slide. So here we have a 62-year-old female with symptomatic disease, stage 4, in need of treatment, high-risk biology, both by Ki67, but importantly with TP53 mutation. So this is a patient who we know has a very poor outcome when treated with standard chemoimmunotherapy. So patients treated with both less intense and more intensive chemoimmunotherapy who harbor TP53 mutations have been shown to have progression-free survivals of about a year and overall survival of less than 2 years. So not, these patients are not responsive to chemoimmunotherapy. And even in, some of the trials like the SHINE trial, they appeared to not do well with just the addition of BTKI to chemotherapy alone, do not appear to do well with our BTKI either. Next slide. So what are we going to do for this patient? So the Bowman trial was a trial that evaluated the use of CD20, BCL2, and BTK inhibitors. So this looked at the combination of obinutuzumab plus the BTK inhibitor zanubrutinib plus the BCL2 inhibitor venetoclax. And this was really based on a few different trials. The AIM study, which in relapsed refractory disease suggested that the BCL2 BTKI combination had activity in these patients with TP53 mutations. And then a few small phase 1 trials that combine CD20, BTKI, BCL2, and seem to have suggestion of activity in patients with high-risk disease. So this is the only trial that had been dedicated to this patient population. So it was a small number of patients, but 25 patients with TP53 mutated MCL treated with this total non-chemo approach. So they used a triplet combination. Patients were treated with 8 cycles of obinutuzumab and then at least 2 years of BTKI and BCL2. They did use an MRD-driven approach in this trial as well. So after 2 years on therapy, if patients had undetectable MRD, they were allowed to stop treatment. If it was still detectable, they continued therapy with both the oral BTK inhibitors. For those patients who stopped treatment, if their MRD became detectable, they were then allowed to resume the oral therapy. Next slide. Primary endpoint of this trial was 2-year progression-free survival. This is a single-arm trial, not a randomized trial, but you can see the 2-year PFS 72% and 2-year OS of 75%, which, if you compare it to the historical controls of chemoimmunotherapy, significantly better, where you have median PFS of a year and median OS of less than 2 years. Next slide. So really, that became my standard approach for patients with TP53 mutations. I use that regimen actually in older and younger patients. Our NCCN guidelines do suggest that both the triangle approach or this approach can be used. So either the more intensive chemo with BTKI or the triplet combination, which I favor. So the TRAVERSE study is another study that I'm just going to highlight. This was presented at ASH, just early results. So this is untreated MCL that uses AVR, so CD20, BCL2, and BTKI, just different drugs. But this it allowed patients with TP53 mutations, and they're using an MRD-based approach to randomize to continued BTKI versus observation and retreatment. So the question, becomes in high-risk patient populations, like in the Bowman study, when they stopped treatment based on undetectable MRD, if that's the right thing to do for high-risk patient populations. Next slide. And this trial, showed similarly very high overall response rates and complete response rates, including if you look at the TP53 mutation patients, with the majority who were undetectable MRD after the treatment, but we don't have long-term follow-up on this. But I think, again, just more support that these triplet combinations with non-chemotherapy approaches are probably going to be our best option for patients with these high-risk mutations. Next slide. So in conclusion, looking at treatment for frontline mantle cell lymphoma, a lot has actually changed in the last 2-3 years here. Treatment is evolving with the use of BTK inhibitors in the frontline setting. They have established a role in all populations of patients. So patients who were previously considered, unfit for more intensive therapy, they can be used in combination with CD20 or in combination with BR in patients who are considered fit for more intensive therapy. They can be used in combination with chemoimmunotherapy, like the triangle approach, and then used in all those with maintenance therapy. And then in patients with high-risk disease, the triplet non-chemo combinations. I think what's not clear and what's ongoing and what we have to think about in the future is the best way to maximize the BTK inhibitors. So in who is a doublet versus a triplet, what's the right triplet combination? They've been studied with BCL2, but also in combination with lenalidomide. Now with the availability of CAR T and bispecifics in the relapse refractory setting, there's ongoing trials or planned trials to look at those BTK in combination with those immunotherapies and cellular therapies, particularly in high-risk patient populations. I think the other question is, how long do you give a BTK inhibitor? The triangle gave it for 3 years. The ECHO study gave it until progression. If you stop BTKI, can you use it to recapture response in the future when patients progress, either clinically or with MRD? So these combination studies are ongoing. And then another thing I want to highlight is, I think the MRD endpoints are the future of MCL. So we've seen, Bovin use MRD, the Altamira trial used MRD, the ECOG study to decide transplant, no transplant used MRD. And I think really, in the future, escalation and de-escalation based on measurable residual disease, potentially, treatment or retreatment at emergence of MRD versus clinical progression are all things that the future holds for MCL. And with that, I will go ahead and stop and would be happy to answer any questions.
Thank you so much, Dr. Kami, for updating us with this wonderful subject. 4 beautiful cases and a lot of discussion and data presented. So we'll have some questions as my colleagues may be thinking of the questions. So would you say that autologous transplant is out in the upfront treatment of mantle cell?
So I think that in patients who have access to BTK inhibitors, the autologous stem cell transplant is out. I think if you're in a situation where you can't access a BTK inhibitor, then I think for the small population of patients who continue to have detectable MRD, that's where there's like a small role for auto transplant, in my opinion, and that would be no access to BTK inhibitor, but still have detectable MRD after induction therapy.
Thank you.
So can I ask a question, sir?
Yes, please.
Thank you for the lecture, ma'am. From your slides, I understood that an upfront BTK plus BR approach you're not offering to all patients. You definitely offer it if they are high risk by the criteria that you mentioned, and on a case-to-case basis, you offer it to the low-risk patients. My question is, what are the cons to offering this to a lower risk patient? Is it because we want to save something for a relapse, or we don't want to add to a toxicity? And would incorporating MRD in this change your decision with the low risk patient?
So my hesitation in some of the low-risk patients are that, there is added toxicity. And there was a trial that was not randomized and will never have randomized, but there was a retrospective study that looked at outcomes like PFS2 of patients who received BR and then subsequent second-line BTKI. And if you looked at the PFS2 of those patients versus the patients that were treated with frontline BR plus BTKI, they look similar. Now, that's not using it in a randomized fashion, but that really brings up the question are there patients that get the same kind of amount of response out of BR and BTKI sequence versus adding the BR plus BTKI alone? So when you look at the, being unsure if you're really providing benefit and you're adding toxicity, and, low risk patients can have very good PFS with just BR or with our BTKI, as we showed. So that's why I hesitate in low risk populations to use the combination, because I'm not convinced that you're improving outcomes, but you are adding toxicity. Whereas in high risk patients, I do think that there is a benefit to adding, the addition. And then, could MRD be used in that patient population? Yeah, I mean, I think you could think about, the MRD, I think for like escalation or de-escalation or the addition of another drug. So, could you give something and then escalate versus de-escalate if they achieve an MRD negative state? I think that's a reasonable question.
If I can ask another question, I know your talk was about the frontline treatment, ma'am, but in your practice, where does lenalidomide and venetoclax feature in mantle cell?
Yeah, so that's a great question. So I do use the triplet combination in the frontline setting, so in TP53 and some other high-risk patient populations. Otherwise, the way that I use venetoclax has been if I have a patient that's progressing on a BTK inhibitor in the second line setting, and they're not eligible for, say, cellular therapy, I will sometimes either use single agent venetoclax or add the venetoclax to the BTK inhibitor in that situation. The issue is we know that those patients have a very short PFS when they're progressing on ibrutinib. So while I will add it or use it, I usually try to do it as like if I'm thinking about bridging them, maybe to CAR, but they can't go directly to CAR. Lenalidomide, I honestly don't use a whole lot anymore with the availability. So pirtobrutinib, the CAR T, venetoclax. We actually just got approval in the US for the other BCL2 inhibitor, sonrotoclax, in the third line setting. And then bispecific antibodies are not approved, but oftentimes we can get them. We can get them to be used in our patients. We did have, I think, lenalidomide in the frontline setting is still an intriguing question. We had a trial that looked at obinutuzumab plus lenalidomide plus acalabrutinib, and that actually was like showed very high overall responses and very high rates of MRD negative disease. So I think lenalidomide is an active agent in mantle cell lymphoma. It just is hard, I guess, with the options to know exactly where to sequence it.
Thank you.
Well, could you elaborate about the MRD testing? What will be the tissue and what is the technology?
So these were all done with the Sequenta MRD, like all these trials were done with that. I think MRD, is that technology is advancing. And I think that is a question that remains for the future. What's going to be the best way to test MRD? But this was all by sequencing, not, this was all sequencing with NGS. There's some variability on some of it was done in the blood and some of it was done in the bone marrow and some of it was done in both blood and marrow.
Okay, right. The question, use of bispecifics and CAR T upfront for high-risk MCL.
Yeah, I think that's a great question, and I think that's where the field is moving. I think the challenge we're going to have is what patient populations is that balance in toxicity versus outcome. So if you look at, there's a trial at MD Anderson that uses an acalabrutinib run-in and then uses the more intensive Brexucab CAR T cell therapy. And they presented data at ASH and they showed that responses were good, but there was a high number of patients that had grade 3 toxicity, grade 3 or 4 toxicity, and ended up in the ICU, with their initial therapy. So I think, in very high risk patients, I think there's a potential role for it, but I think the question is, do we have better or less toxic CAR T cell therapies? And then how high risk does your mantle cell have to be to balance the risk of, CAR T in the frontline setting? Because it did appear to have higher rates of toxicity. There is also a trial looking at glofitamab plus lenalidomide at City of Hope in the frontline in high-risk patient populations, and that they just presented very, very early data, but that looked like it could be positive. There's a planned large randomized trial to randomize to bovin plus the use of bispecifics in the frontline setting. So I think that'll, give us some data. I think that, bispecifics probably are more promising just because they would be probably better tolerated. And then in Europe, there's actually a randomized trial that's looking at induction therapy. They're including more intense and less intense induction, and then consolidation with CAR T as well. So I think that is the future, but I think the challenges are going to be, what patients are high enough risk to take the risk of giving them a more that toxic therapy. And then if we do have 2 products here approved in the US, and one product does have a much better toxicity profile, so what's the best product when you use CAR T in like the frontline setting?
Thank you. In the leukemic presentation of MCL, still the policy will be wait and watch?
Yes, but so for patients with non-nodal without a TP53 mutation, and then those patients, even with low risk disease who are asymptomatic, low tumor burden, normal labs, then yes, there's still a role to watch and wait.
And in a newly diagnosed case now, you will not use ibrutinib. It will be invariably Acala or Zanu?
Correct. So with ibrutinib is still used in most like in a lot of parts of the world. But here it's not even, its indication's been withdrawn, and they actually stopped making. You could get it if you tried, but we use Acala and Zanu in the frontline, in the frontline setting. And really in the relapse refractory, we pretty much use the 2nd generation BTK for mantle cell.
Right. Any more questions from anybody?
Are you still considering allogenic transplant for any of your mantle cell patients?
So that's a great question. For us, because of the availability of CAR T cells, if we're in that patient, in high-risk patient populations, they're heavily treated and that have not been exposed to cellular therapy, I use cellular therapy. The patients that I have referred for allotransplant, I do think for patients who progress after CAR T, I have a few that I've treated them with a bispecific and they've responded, and I referred them to allotransplant because I think, there's those, we don't know that either of those that's a curable situation when you've relapsed post-CAR. And I do think there's still a role for allotransplant. For patients that don't have easy access to CAR T cell therapy, with high-risk disease, so patients with TP53 mutated disease that don't have access to CAR, I also think that there's a clear role for allotransplant in those patients, and there is some data from Memorial Sloan Kettering on that.
Thank you.
Looking ahead, you feel the treatment of MCL will become chemo-free?
I do. That's my opinion.
Right. Any other question? In that case, Dr. Kami, thank you very much for sparing your time. It was wonderful, enjoyed it, and learned a lot.
Thank you, guys. Thanks for having me. Sorry I couldn't get my slides to share, but have a great day.
Bye-bye.